on this Q&A for COVID-19. I'd like to welcome Professor Adrian Newland. Welcome back to Dr. David Kuter, and welcome back to Dr. Nichola Cooper. Adrian, you got some questions?
Yes, I've got a few questions. This is obviously a very popular subject, and we have 10-20 minutes lined up, but we could go over a little bit more if need be, not too much more, but we'll try and answer the questions. I think let me just kick off with one that's very topical at the moment that came through from the JCVI, the Joint Committee on Vaccination and Immunization, yesterday, with the advice that patients, that people receiving vaccines, now if they're under 40, should not receive the Oxford AstraZeneca vaccine. And I just wonder if any of you have any thoughts about that. I know, David, obviously you don't have the AZ vaccine in the States, but what do you feel about the balance of risk? I know, Sue, that you've already commented on it for the Science Media Centre. Would you like to say something about that?
Are you asking me, Adrian, or David?
Yes, yes. Oh, Sue.
Yeah, absolutely. Well, this has been of great concern to us, the vaccine-induced immune thrombocytopenia and thrombosis. It's a completely new syndrome, and I think that's important to emphasize because it's so unique. We've actually only known about this for 6 weeks, this condition. And so we've decided on a case definition, but we need to be very open-minded to what that might be. Now, what we're seeing is that this does affect anybody of any age and both genders equally, but it tends to have a more dramatic presentation in young women. And I think that's why originally the JCVI said we should perhaps offer alternatives to individuals under the age of 30. Now, because the COVID pandemic has been brought well under control in the UK by such amazing sort of vaccine rollout, the risks of COVID-19 to the under 40s is now outweighed by the risk of the AstraZeneca vaccine and this VIT problem in the under 40s. So they've now raised that cutoff.
Yeah. But I think it's an interesting point because I think looking at the reports, there are about 140 of these cerebral venous sinus thromboses in the Oxford AstraZeneca. That's out of, it's pushing 30 million vaccine doses in the UK. The 20 million Pfizer, there's something like 16 reports on yellow left on the yellow card reporting. Now, is this the sort of numbers you would expect just in a normal population, or is there a feeling that the Pfizer one could be causing this as well? And I know obviously the JJ in the States has been, which is the adenovirus variant, has also been associated with a small number. But these numbers are still within what you would expect in the normal population. And I wonder if any of you would like to speculate on that. David, would you like to comment?
Well, again, it's not been a public health menace by any means in the United States. It's put a hold on the J&J vaccine reinstitution a couple of weeks ago, but it's now been relicensed by the government for emergency use with a warning that this may be an issue to happen. We have really not seen any cases in the Northeast that I can validate as being a sign of this phenomenon, VITT. It's a different kind of thrombocytopenia than ITP for sure. But I've probably seen more cases of cerebral sinus thrombosis from other things like birth control pills in the last 2 months than I have from vaccines. I'm not here to belittle it by any means, just trying to say it's a rare side effect that we're learning is a brand new disease. It's a brand new problem, but it's not a huge medical risk, I think. And what I'd like to ask, if Sue knows the answer, is there any data from the UK that the women had birth control use at the same time?
It doesn't seem to be increased by hormonal preparations. It seems very much an idiosyncratic immune reaction, as you've said, and it's a really novel syndrome. It's the combination of this intense activation of the coagulation system with very raised D-dimers and a low fibrinogen, which is D-dimers are higher than we would normally see for thrombosis. and the platelet count can be really very low. So that combination in our field is extremely rare to see. I mean, there's only sort of 4 conditions really that do that. There's PNH, which we've excluded. There's TTP, they've got normal atoms. There's antiphospholipid syndrome. Many of them have false or a transient positive lupus anticoagulant. And then there's heparin-induced thrombocytopenia, and it does seem most aligned with that, although occurring in the absence of heparin, that has been described before, this spontaneous heparin-induced thrombocytopenia, and it's related to these platelet factor 4 antibodies that are present. So they're not present in cases of COVID infection with thrombosis or other cases of thrombosis. It's quite specific to this VIT condition.
That's an interesting point. So I'm assuming that the cerebral venous sinus thrombosis seen following the Pfizer vaccine, the small numbers, are actually just CVST. They're not related to the vaccine at all. They're a different animal, really.
I think the real concern is what do you tell patients who are concerned about this? And we've basically said that we think, at least in the United States, that there are options, and if there are other options, a non-J&J vaccine is ready available currently. We have a vaccine excess right now, unfortunately. I think I also tell patients that if you had a vaccination, have a new onset of headache or a sign of thrombosis, that ought to seek attention. And thirdly, if your platelet count's low, then they should, in a new thrombosis, we will automatically check this HIT test, which is widely available, to see if they fall into that group of patients.
Yes.
And so I think
I was going to say there are enough vaccines in the UK that there won't be a delay by offering an alternate vaccine in the under 40s. Although the suggestion is if you need to give a vaccine, it shouldn't matter. Sorry, Nikki, you were going to comment.
No, I was just going to say that I think one of the things for some sort of reassurance is the system that Sue's really coordinated, which is this meeting to discuss cases. And I think it's fair to say, Sue, that you're catching patients earlier, and actually we are treating. So there is treatment to intervene, I think that, and so the disease itself, I think, is changing, isn't it?
Yeah, I think that's absolutely right, Nikki. I mean, when we first knew about this condition, there was a 50% mortality rate, which is very high, much higher than we would see in just thrombosis. Because of raising awareness and early recognition and identification of cases, and some preliminary treatment with intravenous immunoglobulin, the mortality rate has come down to 19%, but it's still very high. It shows what a serious condition this is. And I think we have a long way to go before we fully understand what measures of treatment are going to be optimal in halting this terrible immune process.
Yeah.
But IVIG has been a great starter.
What do you say?
Do you think we've missed this in other diseases? Do you think we've missed this with other vaccinations?
We've missed this?
Have we missed this with other vaccinations that have been given to the public?
Unlikely.
Well, yeah, I mean, there is a look back being arranged going back to January, when we really started our sort of proper vaccine rollout in the UK. There's a look back going to say, have there been any retrospective diagnosis? It's possible, because we started vaccinating older people. It's possible that some were underreported or not reported because they were strokes or heart attacks that were put down to their age or other comorbidities, rather than thinking, gosh, this is a week post-vaccine, could it be related? So it's likely that there are some missed cases like that, but it's when we started rolling out to the to the younger age groups, that this condition really became apparent.
And I think one of the differences here from other vaccines, of course, in the last 4 months, we've vaccinated millions of people. So when you vaccinate so many people at the same time, you're bound to get these very rare things that may or may not be related to it picking up, because you've still got the background problem in the population. So it's a very complicated issue, isn't it?
Yeah, it is.
What do you say to the patient who's had a previous episode of thrombosis? I don't mean cerebral thrombosis or related to this in any way, but who's had a thrombosis and comes to you very worried about what vaccine they should have, or should they have the vaccine?
Well, there is no evidence that they are at increased risk of developing this immune reaction. And certainly of the 200 cases that we've analysed, there were only 3 with prior DVT and PE and none with other previous thrombotic history. So it doesn't appear that those people are more at risk.
Okay, just changing it slightly and coming back to the issue of low platelets and vaccines. Obviously, we've got an audience here of patients with ITP who are worried about both their disease and their susceptibility, often related to treatment, but are worried about their count at count at the time of vaccines. What do we say to those? What sort of level of count should we be feeling comfortable at vaccinating, or should we give something to bring the count up to a higher level? Nikki, do you want to comment?
Well, I was hoping you weren't going to come to me on that one.
We could go to the American angle.
I mean, I think I guess we have no evidence of that, do we? And I think ideally, I think we would all feel comfortable if people had a safer platelet count. But actually, the reality is, for some people, they have chronic thrombocytopenia and very difficult to treat, and so it is a balance of risk. And I think what Sue pointed out, that actually at the moment the risk of COVID in the UK is very happily low, but I think prior to that the risk of dying from COVID was significant. So I think we're still trying to encourage people to get vaccinated, and I guess most of us are trying to keep patients with a platelet count above 30 anyway. So if they're lower than that, it's probably because they're refractory to treatment, or we can't find a treatment that's tolerable. So I think at the stable count that they're usually at, we haven't intervened. I don't know if anyone has a different opinion on that.
But David, you touched on this a little bit about problems after the first vaccine and then going on to the second. Would you like to comment on that?
Yeah, so we've analyzed the data, which the talk I gave was taped about 10 days ago. So we've analyzed a lot more data since that time on our patient population. And those who've dropped their platelet count significantly have done it on average of 2 or 3 days after they received the vaccine. Their platelet counts have dropped to below 10,000 invariably, and people have had increased bleeding. That's in about 12% of the total population. So this happens really fast when it happens. Whether your platelet count's high or low beforehand didn't seem to predict who dropped their platelet count. So many of our patients who were in so-called remission, half of our groups had remission, then dropped their platelet counts in 3 days. The other patient populations had low platelet counts and also dropped them. So there was no association of who dropped their platelet count and how low it went based upon their prior pre-treatment platelet count. So I've been advising our patients to go and get the vaccine. The good news is that out of the 7 patients who dropped their platelet counts, all of them got treated with corticosteroids for under a week, and 5 of the 7 had their platelet counts normalized in an average of 3 days. So yes, the response time was analogous to people having a drop with a prior infection. So good news is that if this happens, it's easily treated and it responds rather rapidly. And so we've recommended that if you're worried about it or have had a prior drop of vaccinations, we get your platelet count drawn 3 to 5 days after your vaccination. The flip side is, what if you dropped your platelet count with vaccine number 1, do you get the second vaccine? We haven't had the courage yet to give a second vaccine to our patients, but I think right now I'm holding back. The good news is we've checked the spike protein antibody test, and everybody who's had this problem, they've all had a rather robust response, which is ill-defined currently, but it's still a response we've measured. So, and we've also measured the spike protein assay in all of our ITP patients who've gotten vaccinated. Everybody's had a very robust response, whether they had your spleen in, or they had your spleen out. So we're actually quite confident that if it's a risk, it's a small risk to take that we can easily fix.
I think the reports, the MHRA with the AstraZeneca vaccine, was that all the problems occur with the first vaccine. And those who had 2 vaccines didn't have a problem with the second if they hadn't had one with the first. But obviously, re-challenging someone with a second vaccine if they've had a problem with the first is a hard call.
Well, Adrian, ironically, 2 of the patients we'll be reporting on shortly, in the 7 patients who dropped their platelet counts that I just talked about, 2 of those patients had a petechiae after the first vaccine. It wasn't until the second vaccine they actually had the courage to get a platelet count. So we've actually given a second vaccine to 2 of our people who clinically had a low platelet count the first time, but we didn't check it. they recovered spontaneously. They got a second vaccine, then they crashed again. Then we measured the platelet count. So I think that this is, I think my message to patients is clinical observation is probably as good as a platelet count, because almost everybody, I should say everybody who crashed had clinical symptoms. And it happened within 2 or 3 days of getting a vaccine.
I think Sue's looked at the figures more recently than I have, but for our self-reported survey of ITP patients, as many had counts going up as fell in some of them, and certainly the early reports were that it was the same with both of the vaccines, but that may have changed with the bigger numbers. Sue, do you want to comment on those, because I think you've looked at them this week?
Yes, that's right. I mean, it's as David said earlier, actually, when we were chatting, that it could be reporting bias. So, but of the 107 people who had received the AstraZeneca vaccine, 16 of them had had a pre and post platelet count checked. And you might think, well, are they just checking their platelet count because they are people who it fluctuates, or who because they have often frequent relapses? So there could be a reporting bias even to start with at that point. But it was interesting to see that of those 16, nobody kept their platelet count stable. They either all dropped, so 50% of them dropped quite significantly, and 50% of them went up. Whereas with Pfizer, there were 14 of the 66 Pfizer vaccinated ITP patients who had had a pre and a post platelet count done. And 13 of the 14 had remained completely stable, whereas one crashed right down to a platelet count of 1, so it was a genuine relapse. So I thought that was an interesting comparison between the two vaccines, where the reporting bias you would expect would be equal in those two groups.
It's a lot of this is self-reported, and certainly the MHRA data is not something you can rely on as hard and fast, because obviously it's again self-reporting. But the thrombocytopenia levels in normal people receiving a vaccine was between I think as 10 and 20 per million, which is probably what you'd expect in a normal population developing ITP. It was about 5% in the ITP patients, so higher in the ITP patients dropping their count. So clearly they are more sensitive to it. But I think in terms of severity, I think we only had one. The data I looked at where the count actually dropped to rock bottom, and that started at 26 pre-vaccine, which I thought was a bit sporting.
Adrian, I've got a question.
Okay, sure.
This is from Caroline, and it sort of links into another one from Susan. Basically, she's saying low platelets and a risk of brain bleeds were things that we were aware of as issues around ITP before anyone had ever heard of COVID. But do the expert panel know if it is a safe option for ITP sufferers to carry on with the AstraZeneca Oxford jabs? And there's quite a few questions on the same vein, or whether to choose another vaccine. And also another question on a similar vein. They're talking about, is it possible to mix vaccines, i.e. they had the AstraZeneca first, which they had a reaction to, and they're asking if it would be possible for them to have the Pfizer as a second vaccine. I know there's a trial going on at the moment, isn't it?
I mean, both interesting questions. Nikki, do you want to leap in and say anything?
I think I'm going to deflect that to Sue, because she's been so much involved with the VITTs, I think. I mean, I think switching, we don't know the data yet. And I guess what we don't know yet is whether the immune response is better or worse. And I think that fact that it is an immune response to the vaccine that's we think is creating this, that actually if you are safe with the first vaccine, you'll probably be safe with the second vaccine. And that's what we've done. But I'm really interested to see what everyone else has said.
And that's the MHRA advice.
Yeah.
Yeah. So I think there's kind of two issues. There's brain bleeds associated with ITP, and I think we still have to analyse the ITP post-vaccine data, but I'm not aware there have been increased brain bleeds in those patients. The brain bleeds associated with VIT are quite different. they are bleeding not because of the low platelets, but because of such extensive thrombosis in the veins that drain blood from the brain, the cerebral venous sinuses. Because when they are blocked, there's considerable back pressure of blood, and of course they're in a confined pressure space because of the cranium, the skull. And so that back pressure causes bleeding, leaking through the capillaries, and that's why we get the bleed. So it's not like because they've got single figure platelet counts, and that's not the case here.
And so it hasn't been a case that the ITP, you haven't seen lots of ITP people getting bit, have you? This hasn't been.
No, absolutely, Nikki. That is absolutely right. The previous history of autoimmune disease has not increased in these cases.
I mean, part of the issue, and I think that's what the JCBI advised yesterday about the under 40s, once the risk of COVID drops to a significantly low level, then even the risks that this would happen naturally increases. But the risk that it may be a post-vaccine effect means that the risks and balances are much more nuanced. Whereas in the older patients, where there's not only the slightly higher risk of COVID, but bigger risk of problems with COVID, means that the balance far outweighs receiving the AstraZeneca, if that's the one you're being offered, than not. And of course, we haven't thrown in the whole issue of long COVID, which you mentioned briefly in your talk, which happens in 20 to 30% of people, and a third of those who are asymptomatic will get long COVID symptomatology, as far as I'm aware.
And I said, just for the small number, the 70 patients we've just analysed, pre and post platelet counts on our ITP patients, 50% have got Pfizer, 50% have had AstraZeneca, and there've been no sequelae at all in that. So I don't think ITP is a risk factor itself. But I think the advice is continuing to change, isn't it, as well? So depending on the information that we get. So I think all of those things are changing.
Yeah, I mean, I agree with everybody. I think apart from the age group where the cutoff has been changed, I think patients with ITP should be considered as with all the population. They're not at increased risk of VIT. They may be at increased risk of relapsing with their ITP, but as David said, it's a problem that can be fixed. And it's so important to be immune to COVID.
Do you have any thoughts, David, about mixing vaccines? I mean, I know there's a study.
This is as Sue said, this is being studied. We've not mixed anyone's vaccine right now. We actually have a problem with patients not getting the second vaccine period. So that's our real issue. So I think that the FDA will be releasing statements on this very shortly as to if you get one vaccine initially, I suspect they'll say it'll be totally fine. I would have no worries about this as an immunologist in training.
And I guess that's the other thing for reassurance. I think the MHRA and all of our governing bodies are doing a huge amount of work to continue to provide safety information, and that does change all the time, and we are all listening to that.
Yes.
I think the other thing I've learned, Adrian, is that the fact that many of our IT patients have no spleen, and the worry was would they make an antibody response. And to be honest with you, whether you have a spleen or no spleen, based upon about 30 patients, we've had equal titers of anti-spike protein antibodies. It's been quite impressive.
That's a very interesting point, because that's certainly been a worry amongst the patients. Mervyn, I guess we could go on for 5 more minutes. Do you have?
That's fine. That's fine. Yeah. I've actually got a question about antibodies from a Margaret. She's concerned that she's had 2 vaccine doses of the AstraZeneca, but she's concerned that she may not actually have the antibodies protecting her against COVID-19, and she's considering getting a private antibody test.
I think that's
Any views on this, gentlemen?
I don't know how available these are in the UK, but we can readily get a anti-spike antibody protein in the United States. There's actually a kit will be licensed by the FDA shortly to let you do it at home. But what's important to note is there are 2 assays, at least in the United States, for COVID. One is that it detects the virus itself, which is testing for the infection, which is negative after a vaccine. What you want is the one that's against the antigen, which is the spike protein. That's a specific test. And many patients come to me saying, well, I got the other test on negative. I'm afraid I'm not protected. It's a specific assay, a specific test ought to be done to prove that you've had a true response. I don't think the ITP patients have to worry about this any more than any other patient does. So I don't have a huge amount of worry, except in patients who had rituximab.
I think it's unlikely they could actually get a private test for antibody in this country at the moment.
Yeah, you can. You can.
Yeah,
there's lots of them.
Are they licensed?
But I think an interesting point is that since the vaccine program started, less than 1% of patients being admitted with COVID had it's greater than 3 weeks after receiving their vaccine. So I think the proof of the pudding really is a little bit in the data for that. Sue, do you want to comment on that?
Say that again, Adrian. Sorry, something distracted me.
That's all right. I've totally forgotten what I was talking about then.
Actually, got another question, Adrian. I've got another question that's coming through the Twitter feed from a Gail. Interesting one. Have the rare instances of thrombocytopenia and blood clots in people receiving the COVID vaccine revealed anything new that could help further the understanding of ITP, i.e. cause, treatment, and clues to a possible cure sometime in the future?
I think not, but I'll hand that over to David.
You've turfed the easy ones to others, but anyway, so I actually think right now that we've learned about a new disease, which is thrombocytopenia with thrombosis, the VITT. I don't think that's going to shed much light on ITP. And I really think right now what this whole vaccine episode has taught me about ITP patients is we actually don't know how to quantify what happened before with prior vaccinations, the flu vaccine, the shingles vaccine, or even an infection. We don't have a hard data to say to an ITP patient, if you get the flu, you've got an 8% chance of dropping your platelet count. If you get shingles vaccine, it's a 3% drop. We don't have that data at all. I'm actually surprised how poor that data set is. So I think that what we've learned is how little data we have in the vaccine world or the infection world as to how badly patients drop their counts with ITP.
I mean, I think we've been quite lucky, as you commented earlier, that some of the databases we've got in the UK are really fantastic at looking at this. And I think SAGE and JCVI have been really superb in putting out data. There's nothing hidden there at all. I think the data is coming out almost in real time, isn't it?
I think we're very fortunate in that, one, we've got these vaccines, which is this makes penicillin look like small potatoes. Yes. I think right now, the second thing is we have a vigilance system right now, which has been highly sensitive in finding even this small fraction of patients who've developed this VITT syndrome. It's a phenomenal observation.
I think, sorry, so I was going to say a take-home message of this is actually how successful this vaccine program has been in reducing the incidence of COVID, and actually considering the number of vaccinations that have been given in a concentrated period, the number of side effects is actually remarkably small, and it is throwing up one or two things that need to be looked at. But I think it's remarkably safe considering the options of the disease itself. So sorry, come in.
No, I was going to say, I mean, that's an excellent point. And obviously our vaccine rollout has just been tremendous in the UK, reducing our risk of COVID infection and freeing up our country. But back to the question about what have we learned, I think in terms of the COVID infection, it's been an opportunity for us to learn a little bit more about ITP, not so much the vaccine, but the COVID infection itself, because we've been encouraged really to change our strategy of treatment. So we've been more cautious with steroids, and we've realised, that the adverse effects of steroids over the last sort of few years really, and that knowledge has been increasing. And I think with COVID around in the environment, we've been more judicious with our steroids, and that's been important. And we've had the opportunity, thanks to NHSE, to be able to use thrombopoietin receptor agonists up front. And we've been able to see how effective they are as first-line treatment. And so if we could now roll this into randomized controlled trials so that we can consider their use outside the context of a COVID pandemic, I think that would be tremendous value of something we have gained and learnt from this sort of terrible COVID year.
I think that's an important point. David, Nichola, do you want to say anything, any final wrap-up comments before we close this? Because I think we ought to, as the next session starts at 3.
Yeah, I think I'd just reiterate exactly what everyone has said, how incredibly important vaccines are. We are in a great place now, but I really think people can't be complacent about that, and that, you know, we are getting better at monitoring and trying to see for any sort of adverse events. But again, just reiterating how incredibly important vaccines are really for everybody, and how many lives they're going to save.
I would just briefly say that patients with ITP should have concerns about vaccinations, but they're not high enough to prevent them from getting vaccinations, with very rare exceptions.
Yeah, I think that's a really important point.
Get vaccinated. And also, if you got no spleen, get your other vaccines.
Yeah. I think those are really good points to finish on, David. That's fantastic. And I'd like to thank the 3 panelists for what's been a great discussion. Actually, we could go on. Mervyn, do you want to wrap up?
Yeah, thanks everyone. I hope the people watching have found it useful.